So yeah, this came out of last year's talk when we did one on the effects of hypertension and exercise and the different effects of pressure or volume, pressure overload on the heart. So what about obesity? And I thought, well, I don't really know about obesity. So I'm going to start with a poll, and I want the people online to also poll, and Esther's going to try and pull in 61 responses from across the ether into this. The first question is, how many of you have put obesity into your cause of death following an autopsy? Okay. Was that in section 1 or 2? If it was section 2, put your hands up.
You need to slow down for the people online. So stick to question 1 first of all.
Right. 6.
So about 11 people online.
So about 11 people online. So rather high proportion here. How many put it into only into section 2 for the cause of death? So that's contributing to death but not directly causing. How many have actually used it in section 1? Okay, a few people have. Okay. How many people? Right, we'll wait for the online call. I'll just keep eating biscuits. It's fine.
There's a number of comments as well. Some people saying they used it in both part 1 and 2.
Mm-hmm.
Some people saying they very rarely give it. Some people just saying once or.
Okay, so people do actually recognise it as a contributory factor to death in some degree. How many people have actually put obesity cardiomyopathy in as a cause of death? Okay, good. Any online?
It's going up, 5, 6.
Or a variation of maybe cardiac enlargement due to obesity.
Oh, yeah, so recognising that the heart disease is driven by obesity.
Yeah.
Okay. I could ask you now what your criteria were.
A massive heart.
A big heart and a fat person.
Yeah.
That's probably going to be the end point of this talk, actually. Right. Okay.
A comment from online, somebody saying I wouldn't know how to define that entity given comorbidities. So I'm hoping that you're going to elaborate on that.
Okay. So that's the way we're going with this. Okay. So Galen was a Roman physician who was quite famous. He wrote some very impressive tracts on this. And he defined an entity which is really obesity as polysarchia, i.e. just too much body, really, or too much tissue around there. And he put it down to a surplus of bad humours. Oh, that's quite fun. He also noted that the fat die sooner. He wrote this line that commented that fat people die sooner than thin people. So he recognised even in the Roman times that obesity was a problem. And it was a problem in the height of the Roman Empire, without doubt, amongst certain groups of people, not the peasants really, but the more affluent people did that. He also treated people for this, and he gave them an exercise of diet, a treatment of diet and exercise, and noted that people got better when they lost weight and took some exercise. So this is nothing new. This has been around for ages. Quite interesting to find that out. So obesity, sort of, we really should define that in the first place. That is really the accumulation of abnormal or excessive fat within the body. That's what we're talking about, just too much fat within the body. And we use BMI as a sort of surrogate way of indicating obesity, and there are flaws in the way in which we deal with BMI. It doesn't really, if you've got a big, powerful rugby player, they're going to have a high BMI, and that's not down to fat, that's just down to muscle. It probably is a bit of fat as well when you look at them, but it is not a good idea to do that. There was a paper published from Oxford which really showed a good correlation of heart weight with BMI, and it actually tracks better than weight in general to do that. So that's very good. And usually, according to the figures, we have to create a BMI, or call people obese in a non-pejorative sense, if they have a BMI of more than 30, and tend to deem morbidly obese as being a BMI more than 40. And it does depend where your fat is, whereas sort of truncal fat is really bad, and intra-abdominal fat is bad as well. But the incidence of obesity is, of course, going up massively with increasing prevalence. This is the World Health Organization's map, and basically the darker blue the color is, the higher the incidence of obesity within the population within those countries are. And you can see between 1975, which is the top one, and 2014, the darker blue colors in Alaska, the United States, parts of North America, Great Britain, and the shades in Europe and Great Britain have all got darker as well, as has Australia and Argentina. In fact, most of the affluent world has got a higher BMI than it had 30 years ago, whether you like it or not. It's just everywhere around. But it has its own disease burden. It creates disease in its own right, which has an effect on the heart, independent of just being overweight. We know it carries increased morbidity and increased mortality, and has increased cardiovascular disease risks and increased musculoskeletal risk. A lot of people around who are overweight, who are requiring hip and knee replacements, who basically have just worn out their joints through excess. And this then means they can't exercise, which then actually compounds the problem in terms of the whole sort of social situation. Behind that, or obesity is associated with a number of metabolic, what we call metabolic or physiological pathologies, like hypertension, hyperinsulinemia, dyslipidemia, type 2 diabetes. So you have a higher risk of having hypertension, and we know the risks of hypertension on the heart if you are obese. It is just there to do that. Hyperinsulinemia, you might have higher insulin, and also a higher incidence of insulin resistance, and hence type 2 diabetes becomes far more prevalent. And they have higher levels of dyslipidemia as well. So they have all the cardiovascular risk factors for coronary artery disease building up independent of that. So it is an important factor in the development of coronary vascular disease, or cardiovascular disease in terms of coronary artery disease, hypertension, type 2, but also obstructive sleep apnea. But also obesity alone, when you take out those factors and just look at obesity and you correct for hypertension, or you take a group of people who don't have hypertension, don't have diabetes, don't have the other risk factors, obesity is bad for your heart in its own right. So you're putting an additional strain on your heart whether you like it or not. It alters your myocardial structure and it alters your pump performance. And often you get subclinical left ventricular enlargement and you start to get cardiac dysfunction. And these are present even in mild to moderate obesity. So even in the group that would be deemed to be BMI 30 to 40, so mild 30 to 35, moderate to 35 to 40, you can demonstrate in the absence of other cardiovascular risk factors that they are starting to get effects on their hearts. So there are many clinical studies that have shown this. And then you get this also background cardiometabolic based chronic disease, which I'll go on to, where the effect of your now cardiac dysfunction on your other organs is also now starting to impact. You get this horrible, vicious spiral of physiological collapse. So the other problem with this is you get effects on on your breathing. So these people get sleep apnea, obstructive sleep apnea, which is associated with pulmonary hypertension. The morbidly obese get what's called obesity hyperventilation syndromes or Pickwickian syndromes, where they just don't breathe properly, probably largely because they've got restricted chest wall movements, they don't breathe well, and also because they're splinting their diaphragms, because the large amount of intra-abdominal fat is actually just pushing their diaphragms back into their chests, and you need a large amount more energy to actually keep your diaphragms pushed down in order to breathe. Now, that is a problem because that compounds how we would interpret changes in the right side of the heart, because if they've got underlying respiratory disease, you'll get right-sided heart changes, which are not necessarily related to their left ventricular function. So that causes a problem. You can demonstrate that they get activation of their renin-angiotensin systems, which obviously with the angiotensin will generate hypertension, and you also get sympathetic activation, so they have a higher baseline activity of the sympathetic nervous systems because of that. Now, it's not clear whether that is driving part of the left ventricular dysfunction or whether it is a consequence of the left ventricular dysfunction. That is to say, as you lose your cardiac output and start to hypoperfuse your kidneys, you'll kick your renin-angiotensin system in, which then generates angiotensin, which is a potent vasoconstrictor, and you start to get your hypertension and you get into the normal vicious cycle. Furthermore, you get lipid deposition and just the presence of excess fat. I mean, I was always just looked at the external fat and just assumed it was related to overall BMI and didn't really pay much attention to it. But actually, the amount of external fat does have effects on the way in which your heart pumps, and I'll come on to that. But also, fatty deposition alters function in the other organs, which has an impact on the heart. So fatty change in the liver will impact on your heart. Fatty change in the pancreas will change your insulin things and otherwise. What happens then is you get hypertension in obesity, but some of these changes predate that. But your circulating blood volume goes up. You actually need more blood. So everybody thinks about fat as being a relatively low perfusion, low activity tissue. And in a resting state in a normal person, it is relatively low, the turnover is low. In obese people, actually your fat metabolism turns up because you've got so much of it turning over, and it actually increases demand. And what happens is you have to increase your circulating blood volume to cope with this, so you'll have a more filled circulation. Your arteries and veins haven't got any bigger, you just have a more filled circulation to do that, and therefore higher filling pressures. You have a higher stroke volume in obesity, independent of anything else, and a higher heart rate. So you are loading your heart and putting more strain on your heart simply by being obese. Anybody still on lunch? Good. Obesity also drives insulin resistance and has an effect on that. And fat tissue is not a benign tissue. It is not a tissue that just sits there and does nothing. It's actually it has an inflammatory component to it. And if you turn over your fat faster and do things, you get increased levels of inflammatory cytokines. And actually, you have a low-level background pro-inflammatory milia against a background of obesity, which actually just means everything is just up a little bit. And that's very damaging because you have constantly circulating cytokines going around, your adipokines change, which alter your whole fat metabolism. And because you've got more fat turnover, you get dyslipidemias within that, with raised LDL, which is the bad lipoprotein, and less HDL, which is the good lipoprotein. This leads you to getting abnormal vascular remodeling, so you get an increased risk of atherosclerosis. And because your heart's working harder, you start to get abnormal cardiac remodeling, which for those of you who were at the last talk when we talked about hypertension and exercise, you get increased left ventricular mass. And because you've got increased left ventricular mass, you get poor compliance in your left ventricle, you get left atrial dilatation. And the prevalent change then in heart dysfunction is you get our good old friend HFpEF, which is heart failure with preserved ejection fraction. So they're getting diastolic dysfunction because they've got a thick-walled ventricle rather than systolic dysfunction. They do get systolic dysfunction as well, but they also get a lot of restrictive changes because of the effect on their heart. So this just gets more frightening when you go into it. Great. So the remodeling in your heart that goes on in obesity, and this happens, again, as I say, this is stuff extrapolated from studies that have been done on obese people, largely through imaging, okay, about what structure goes in the heart. And so these patients are well controlled for not having hypertension, for not having hyperlipidemia. Well, they probably have a bit of hyperlipidemia, but they don't have hypertension. They don't have all the other normal risk factors for that. These patients get left ventricular hypertrophy. So if we talk about what are the criteria for diagnosing obesity cardiomyopathy, one, your heart's got to be too big, by whatever criteria you use. Okay, you get cardiac fibrosis, and just in the same way with hypertension, it tends to be a predominantly increase in perivascular, but some interstitial fibrosis as well. And that's a sign that your heart is becoming stiff. And functionally, they get diastolic dysfunction because they basically get non-compliant left ventricles to do that. That raises your filling pressure, which in itself will drive changes on the right side of your heart. As soon as you start raising left ventricular filling pressures and you get diastolic dysfunction, you push yourself into getting potential right ventricular dysfunction. So assessment of the right ventricle becomes important. And we did a talk on that 4 or 5 years ago. Maybe it was worth revisiting at some point. So fat accumulation drives the high cardiac output, and it's particularly the metabolically active visceral adipose tissue. So that is around the organs of your body. So in the gender neutral way that we now speak, what is known as male pattern obesity, okay, which is putting it on in the abdomen around your visceral organs, unlike females, where for some reason it goes on the thighs and the buttocks, but later when they go through the menopause, they tend to redistribute to a male pattern of obesity. It is a fact. I'm not being sexist, but it is just about what happens. You can also demonstrate changes in nutrition and changes in the gut microbiota. So this is the sort of resident population of organisms in your gut change in obesity. You can show difference in your flora in your bowel. And you also get, because of the neurohormonal activation, just as we saw in hypertension, you get changes in cardiac energy metabolism. So this constant drive in the heart that we see in hypertension, but it also seems to be true in obesity, means that you do not utilize your energy resources as efficiently or as effectively as you used to. It goes to waste. You get disconnection of your electron transport changes, so you need more substrate and turnover to generate the same amount of activity within your heart. It becomes inefficient in its energy metabolism to do that. And that seems to be something that happens when you chronically load heart. In exercise, you reverse that, you become more efficient, but that's because you're intermittently loading your heart. And it's due to changes within the myocytes themselves. So increased blood volume, factors affecting that, you get sodium retention, activation of their RAS activation, sympathetic, but you also get downregulation of natriuretic peptides. So the ability to pee out and get rid of your excess sodium disappears when the blood volume expands up. Increased cardiac output, and abdominal adiposity in its own right seems to be associated with an increased risk of high output heart failure. So it seems that the requirement for more blood flow for higher stroke volume is driven more by having abdominal fat rather than peripheral fat on your body. You also get increased arterial stiffness. You get increased advanced glycation end products laid down in the walls of vessels. They become thicker and stiffer, and you get increased blood pressure. But it also increases, because of wall stiffness, you get increased pulse pressure rates. So the systolic diastolic gap widens. And you can also demonstrate that people have an increased peripheral vascular resistance. And this may be related to sympathetic activation being increased, that you have a chronic increase in your vasomotor tone, and that drives that. And you can demonstrate that you have the peripheral resistance is correlated inversely with BMI if they remain normotensive. So it's not a function of hypertension per se, there is just a drive to this. So the heart is working harder, even at normal blood pressure, to maintain perfusion. You get changes in left ventricular wall stress. So you get eccentric hypertrophy, and eccentric in this sense, this is about cardiac remodeling, where you get eccentric modeling means it's disproportionate to the size of the heart. Okay, it's about the ratio of the wall thickness to the cavity dimension. It's eccentric, not an eccentric in the sense it's only one portion of the wall. And it does that in order to accommodate for the left wall stress, and that contributes to diastolic dysfunction, and you end up with your heart failure with preserved ejection fraction. And there are no good therapies for that. Systolic function, you can just flog the heart. If you have systolic dysfunction, it's easier to treat. You either offload the heart by vasodilating, or you stimulate the heart to drive faster, and so on. So that's easy. But once you've got HFpEF, there's not a lot you can do about this, because you've got a fixed heart that doesn't regulate very well. Increased left filling pressure, as I said, leads to pulmonary hypertension and the raised right ventricular end diastolic pressures. Pulmonary hemodynamics, of course, as we said, there is respiratory disease and respiratory dysfunction, ventilatory dysfunction really, associated with obesity, which is the changes of both obstructive sleep apnea and the Pickwickian syndrome that leads to hypoxic vasoconstriction, and again, a further increase in there. Now, in terms of our post-mortem, we can identify that you've got a thickened, heavy left ventricle. We can say a dilated, thick-walled right ventricle. We can't tell what their breathing pattern was like in life. So we don't really know, from our point of view as pathologists, to what extent our right ventricular changes are driven by ventilatory problems or driven by left ventricular dysfunction. But bear in mind, the second commonest cause of pulmonary hypertension in the UK is is left ventricular dysfunction. That's the second commonest cause. The commonest is COPD. So, that's what the problem is. And those of us who work in transplant centres know that if you've got raised pulmonary pressures, you can't transplant because the right ventricle will fail when you put in the new ventricle, and therefore we put people on VADs so they've got time for their pulmonary vascular resistance to come down. So you get an inflammatory milieu. I think we've got this one around. And you can demonstrate within fat as it increases, you get abnormal numbers of inflammatory cells. You can find B cells and T cells, but it seems to be mainly macrophages that are problems. There are dendritic cells and natural killer cells in there. And you get increased levels of TNF alpha and IL-6, both of which are negative inotropes on the heart. So this whole chronic inflammatory milieu actually drives down cardiac function by the negative inotropic effects of the inflammatory mediators, which also drive insulin resistance and abnormal revascular modeling and things so on. And then you've got changes in the leptin and adiponectin, which I'll come on to later. So if you look at the structural changes, echocardiogram, one of the key things seems to be left atrial enlargement. And as pathologists, we're actually very bad at assessing how big is when is the left atrium abnormal at post-mortem. I have an idea in my own head about it, but if you ask me why, I probably couldn't answer you. And we also know if you look at hypertension literature and the effect of hypertension, left atrial enlargement is an independent prognostic factor for death in people with hypertension, i.e. it is a sign of left ventricular diastolic dysfunction and has a high incidence of death. So it's an adverse prognostic factor. MRI structures shows you get increased left ventricular mass and then diastolic volumes associated with the obesity. And these again in patients who are not hypertensive and don't have other risk factors. This is purely an effect of obesity. The left ventricular modative is that you get hypertrophy, which can be then added to by hypertension, but is independent of hypertension. And you get reduced systolic and diastolic dysfunction, and this has been particularly shown in obese young women, where there have been larger studies done. So your heart changes quite dramatically, and it's very, very similar to hypertension, even in normotensive subjects. The ejection fraction is often normal in these patients. They don't have reduced ejection fractions, although ultimately will go on to get that. And they have a higher incidence of HFpEF, again, like the hypertensions. You can measure various things on echo, like mid-wall fractional shorting, and that is used to indicate systolic dysfunction, i.e. you're not contracting well. And even people who don't overtly have systolic dysfunction will have it subclinically that is detectable on echo. So whilst I've emphasised the importance of diastolic dysfunction in this, they have subclinical systolic dysfunction as well to do that. And when you read the echo literature, which is torturous at the best of times, they talk about increased torsion and untwisting rates within the heart as a way of compensating for this. This is a way of, the heart doesn't just collapse down, it actually twists to squeeze out when it turns, and the heart does that more with more muscle mass to try and compensate and push out more blood. So in summary on this, your diastolic dysfunction, and it doesn't matter which study you look to, seems to precede systolic dysfunction in most studies, leads to right ventricular dysfunction, and then right ventricular dysfunction, atrial dilatation, leads to an increased risk of atrial fibrillation. And because diastolic dysfunctional hearts are dependent on pressure for filling, you need pressure to fill a stiff heart, okay? Atrial fibrillation is bad for you, particularly bad, because you need that 20% kick from your atria contracting to fill your heart. It gives that last little bit of filling into your heart. And people with diastolic dysfunction are particularly vulnerable to atrial fibrillation. They get particularly sick when they flip into atrial fibrillation. I'll have to compensate. So all these secondary things happen around that. So what are the underlying things within this? Well, there's no doubt there's a chronic activation of inflammation that occurs in obesity independently of everything else. You get immune cells recruited into adipose tissue. You can demonstrate higher levels, particularly of macrophages in proportion to the number of cells. And you get also T cells there, you get B cells there, dendritic cells, natural killer cells. The whole repertoire of cells are there to do that. There are a number of cytokines and particular adipokines which are important in this: adiponectin, leptin, resistin, lovely name, TNF alpha, and interleukins do that. When we think about adipose tissue, we have white and brown tissue. Obviously, brown is the sort of small, white fat cells is what most adults have. Brown fat is more common in children, and you do have some residual brown fat. It has different metabolism to it. It's not really storage, it's a high turnover system to do that. And then within white adipose tissue, we differentiate between visceral adipose tissue, as I said, and somatic adipose tissue. And visceral adipose tissue is the one that is particularly bad to accumulate. So if you accumulate it on your outside of your body, it's not too bad, but on your inside of your body, that's a bad place to get it. But for all of us, somatic adipose tissue is the largest reservoir for our fat storage. And when it becomes hypertrophied, you can show increased rates of lipolysis within it. It's constantly turning over. It's not just a passive tissue. You've got increased inflammatory cytokines and reduced adipokines there. And these lead to insulin resistance. And if you've got somatic adipose tissue fails, you get increased visceral adipose tissue, and that's when it also gets even worse. Around the heart, you have different groups of tissues. You have heart epicardial adipose tissue, you have pericardial adipose tissue, and you have perivascular adipose tissue actually within the myocardium. All of these will increase in proportion to your overall fat content. So fat people have a lot of fat around the heart. They have bigger pericardial fat pads, but they also have more fat around the vessels. So many of us have looked at right ventricles in large people where there's a lot of fat infiltration in the right ventricular wall, and we've all scratched our heads and wondered about arrhythmogenic cardiomyopathy, and it isn't. This is just fatty infiltration of the heart, but that does correlate with it. And those of us who remember the early days of arrhythmogenic right ventricular dysplasia, it was called, remember there was the fatty type and the fibrofatty type, and we now accept that the fatty type is probably physiological and not associated with risk, and the fibrofatty type is the true genetic problem related to desmosomes. So, but we do recognise now that actually any fat infiltration of the heart may not be good because you are creating this local inflammatory milieu within the heart. So it's been demonstrated that epicardial adipose tissue is a surrogate marker for visceral adiposity. That is to say, you grow the amount of fat on the surface of your heart in proportion to the amount of visceral adipose tissue you have elsewhere. So it is a correlate that works. It has an effect on the heart directly, which has been demonstrated. You get increased heart mass, so we say they've got heavy hearts. Part of that is the increase in fat. It's not just increased muscle mass at all. But it does lead to derangement of right ventricular geometry. You can demonstrate on echo that right ventricular shape changes and the pumping efficiency changes because of the fat. And the right ventricle is prone to this because it is a thin-walled, low-pressure. It is a thin-walled, low-pressure system, and therefore it is much more easily distorted by having all the fat around there. So it adds additional mechanical stress on the ventricles, particularly on the right-hand side. Increased fat in the myocardium is associated with altered free fatty acid usage and more lipotoxicity. So you tend to generate, where you get lipolysis, more free radicals, which can be damaging to the heart. And we know that 70% of the metabolic substrate for the heart is free fatty acid. It's its preferred one because it's the most usual. And also, we know, looking at fat, that you can demonstrate there is locally produced inflammation within the myocardium. So it's not just a systemic inflammatory thing that's going on generally within the body. There's actually a locally induced inflammation around the heart with the fat. So you basically have swathed your heart there on the right in a sort of low-grade inflammatory milieu, which is restricting the heart and distorting it there. So here we have what happens in the obese state. Generally, what happens in terms of this, there's your fat. It's got increased fatty cells. You've got increased inflammatory mediators in the top right, TNF alpha, IL-6, IL-1 beta, IF interferon gamma. all the usual culprits that we associate with systemic inflammation of any sort. These days, microRNAs expressions are increased in certain levels. You can show changes in metabolites, and you can show changes in leptin and resistin, which are specific cytokines or released from fat cells, which increase your heart rate, your blood pressure, and also contribute to systemic inflammation. Whereas in the normal state, you have things like adiponectin, which actually is a downregulator, anti-inflammatory type thing. So you switch from adiponectin to leptin and resistin, which is not good for you. So systemically, it releases lots of anti-inflammatory adipokines, things like adiponectin, but you get a decreased adipokines. If you have adiponectin in the system, in your normal steady state, this reduces your myocardial oxidative stress. That's a good thing. And you also get less IL-10. IL-10 is, in the normal state, anti-inflammatory, but if you're obese, you reduce your IL-10. So not only do you get increased pro-inflammatory cytokines, you get reduced anti-inflammatory cytokines within obesity as well. On the pro-inflammatory side, the specific ones are leptin and resistin. Resistin is secreted largely by the macrophages, and they are being demonstrated in animal models to mediate left ventricular hypertrophy and also contribute to systolic dysfunction. So you can put these things into animals and the hearts don't get bigger and don't work very well. Whether we're all mice or not, I don't know. Macrophages within the heart, and you get macrophages in the fat, not only promote hypertrophy, but they also impair systolic and diastolic dysfunction by the secretion of cytokines within there, in particular IL-6 and TNF-alpha. And for those who read the heart failure literature, those have been identified systemically. If you measure them in people with heart failure, they're elevated, both IL-6 and TNF-alpha, and are independently related to prognosis in heart failure, because heart failure in itself generates a pro-inflammatory side. You also find they secrete things that activate matrix metalloproteinase and activate fibroblasts, which probably contribute to the fibrosis that occurs within the heart. So it's a locally driven process, largely through macrophages, that seems to be occurring. Insulin resistance, any inflammatory action leads to insulin resistance, and they are more prone to type 2 diabetes mellitus. And given that they have changes in their energy utilization, the failure to become insulin resistant, so you can't take glucose up into your myocytes, just compounds the problem about how you drive your energy within your heart. And if you remember, I think your heart uses some prodigious amount, like 6 kilograms of ATP a day. And if you you have enough ATP in your myocyte for 6 contractions or 10 contractions, that's it. So, and that's why cyanide is such an effective poison, because basically it just stops your oxidative metabolism dead, and that's why you die so quickly with cyanide. Useful piece of information. But there you go. I don't know where that came from. But so within you have the inflammatory milieu, you've got the functional changes, the morphological changes in structural heart. You also alter your cardiac metabolism, very similar to the way it does in hypertension. So your increased wall stress, of course, leads to increased myocardial oxygen consumption, so you actually need to generate more energy to do that. That pushes you towards fatty acid oxidation over glucose, and there you get reduced oxygen efficiency and uncoupling of your mitochondria, just the same as you do in hypertension. So your heart becomes less efficient at using the energy that it has and generating ATP for contractions. So it just does not work as well. And if you've got increased demand, you can still have excess fatty acids and you get lipid accumulation and cardiotoxicity. So you can actually get lipid within the cells, and we know you get fat accumulation into the myocytes. It's a bad thing for your myocytes. They don't really work. Why they keep taking it in and doing that, nobody quite knows. It's saving it for a rainy day, but it gets to be excessive. So that's really just a sort of pictogram just to show the various energy pathways that get affected. But you end up getting fibrosis, inflammation, reduced cardiac contractility, and all the components for cardiomyopathy. So, back to you, love. Obesity cardiomyopathy, does it exist? We'll take a vote on this. The question is, have I convinced you or not? Oh, we can put your hands up in the room, and we'll see what Esther gets on the poll, and I'll drink cold coffee.
So it's hand up if it does. Is that what you're asking?
Okay, yeah, let's do it that way around. Does it exist?
Yeah.
That's pretty good. Got most of them convinced. That's good. Not our cardiac surgeon, that's a shame.
I wasn't sure if I was allowed to vote.
I think given your contribution before, you get an honorary vote. You get an honorary vote. It's fine. We won't count it, but you get an honorary vote.
Lots of yeses online.
Lots of yeses online. So most people do believe in it. I certainly do now. I did before, but I'm even more convinced than I ever was before. Having said that, is it reasonable to ascribe it to a cause of death? Yeah, some of you already have, but would more of you do so now? Now you understand what's going on. General nods. Are there people nodding on screen?
There are nods and yeses.
Good.
What's the criteria?
So this said there'll be a panel discussion, which usually means Kim and myself. But anybody else who wants to come to it, what criteria should we use? There is another slide. But basically, I now throw it to the room and say, okay, if you're going to use this, and I've convinced you all that it's an entity and you can use it, under what circumstances would you use it? Because if you look in the literature, there really is nothing for us as pathologists to say that we should be using it. And I think it is an increasing problem. I think it is there. I would say to you, and this is the benefit of personal experience, is it makes families uncomfortable when you give a cause of death. Basically, just they died because they were too fat, and it is why they died, but they don't like it. So you've got to be fairly robust about your arguments for saying this. And you get phone calls from the coroner saying the family don't like this. And I go, yes, but it's true. And the coroner says, yes, I know, but they don't like it.
Can you ask the online people to send in what their criteria might be?
Yes.
Because there's going to be a lag between what you're saying and what.
No. So I think the thing I was going to say is, what criteria should be used? We'll do a parallel, we'll have a conversation in here, which they can overhear. But if they've got any criteria that they would want to use, or what they would use, or will consider, or any questions about criteria, let's have them all up now, and then we can talk through it.
Just to say, Stephen very cleverly created a poll online. So for your first question, does obesity cardiomyopathy exist? And you had 30 people, so 93% saying yes, it exists.
That's better than Boris Johnson got.
6% said maybe, and nobody said no. So you basically convinced everyone.
Brilliant. You can fool all of the people all of the time. But what criteria would you use? Go ahead.
I mean, maybe first thing I would exclude causes like if they're very obese and immobile and lying in bed. I would think maybe if they had PE or something first.
Oh, I think taking all things equal, we haven't got another cause of death.
Okay.
Yeah, I think if they've got a PE, you're not going to say that. You might want to put it down under 2 as obesity because they're immobile for sure.
Yeah.
But I think we got to the stage of saying they're dead. We're assuming they're probably going to have a big heart, but how big?
Yeah.
And you think the heart disease is related to that. What else do you need to know? What other criteria would you use?
Like acute, should not like the drug. Also then.
So should it be both right and left ventricular hypertrophy? I guess they always go together in this.
Okay, that's a good question.
So can you apply the Fulton Index to something like that? I'm aware there's another comment on the back.
Sorry, this isn't a criteria. It's more just picking up on what you just said about families being offended, just as an interesting point of discussion. I'm really passionate about lifestyle medicine and preventative medicine. And I've had multiple discussions with doctors who said that they feel uncomfortable even telling patients that they're obese and how that relates to their disease. Relating to that as well as how you mentioned on your causes of death, how that could offend families as well. But what do you think? Is it our duty as a doctor to educate the public? And when we look at sort of Office of National Statistics and causes of death and things like that, is it not really important for us to put obesity, cardiomyopathy, if that's what we think the cause is, regardless of the offence it could cause to people.
Okay, so going into the sort of morals and ethics of this, I think I would agree. It is our duty to actually say what it is. I mean, the ONS figures are used to, strangely enough, the ONS death figures are used to inform health policy in this country. Okay. More resources have been put into Scotland for ischemic heart disease than England because they have more ischemic heart disease deaths than there. But that's because they record deaths in a different way and work under a different system, and and they eat deep fried Mars bars. I mean, is that fair off?
So question differences in health as well.
Yeah.
In parts of Scotland where it is.
But it is used, and therefore I think there's that. But then again, how many people, if they've got the person dies of lung cancer, put smoking down in the cause of death? I mean, I do occasionally, but I know it's there, but I don't put it down, hardly ever. But you know, it's the same. It's the same idea behind it. It's about informing public health policy and being honest about that thing, about lifestyle choices, about death or life.
We might ask, actually, as a generic question, how fat is fat? How obese is obese?
Well, that's one of the criteria. How obese do you need to be?
Yeah.
I've got an anecdotal one for
The
that.
problem is that the reference ranges are changing because we're getting fatter. They're just saying it's more normal to be fat, whereas it probably should be what it was
So
60 years ago.
if you're right, if you look at the height and weight charts from 1900 or so, these were basically people who might even regard as malnourished, and possibly were.
So just because there's more obesity doesn't mean we have to normalise to
No,
it.
exactly like me.
Oh, there's more obese people. Oh, that must be normal then.
Yeah.
No, it's
No,
still
so
obesity.
they should, yeah.
Stop moving the goalposts. Sorry?
Well, it's a better diet availability. So if you look at the turn of the last century, there was less food, less sanitation, etc., etc. So that is one thing. The question is, what is obesity? How fat do you have to be? And then you get to the question, well, if you're going to upset somebody, well, you can actually just change the words to basically raised body mass index. That's often as a way round it. You know, so,
What do you mean by that, Professor? What do you mean by that?
Well, I've
I mean, they're fat. Oh, obese. Okay, fine.
I've just done that occasionally to when people have really kicked off in court. And I've said, well, look, why do we call it that? And everyone says, oh, yes, that's good, and walks away. But the reality, you're still calling them obese. You just haven't called them morbidly obese.
So I mean, okay, accepting Des's comment that there is a population drift in weight and BMI, if you were going to ascribe obesity cardiomyopathy, how obese would you want them to have been and for how long?
Sorry, going back to the BMI, I think BMI can be affected by height. And there is a study showing that the abdominal adiposity is a major contribute to the obesity cardiomyopathy, regardless of the BMI. BMI, if you have a tall person, BMI would be just overweight, not morbid obese. So that would be another index, telling if the patient have a risk from the fat that he has got in his body, in his heart.
And in obesity clinics, they use measures like abdominal girth and abdominal fat fold thickness as measures rather than BMA purely, because they are looking for that abdominal obesity issue. And I suppose we could put a tape measure around everybody's abdomen and measure that, provided they haven't got a substance.
At lunchtime, yes. Let's go to Esther, because she's got sort of a summary of the online votes on what's going on.
There's quite a lot of comments actually. First of all, Siobhan Fraser in Glasgow was shouting at the computer, agreeing with you, Martin, about obesity and drifting.
I love her. Who's she?
So we've had several comments suggesting some criteria. Rebecca West talks about, says, I think the heart should be increased in weight, although when you're looking at between 0.4 and 0.5% of total body weight in obesity, that's meaningless, so that doesn't particularly help. But she asks, should we specifically require right ventricular hypertrophy, fatty infiltration histologically, or increased epicardial fat? So those are her suggestions. There is a suggestion from Gemma Kemp from Glasgow, who puts obesity in the cause of death if the BMI is over 40. Mayuri Basnet says criteria would be high BMI, heart rate more than average for the height and weight, fat in the myocardium, not much fibrosis in the myocardium, rule out other causes of toxin histology, but sometimes difficult to differentiate between hypertensive heart disease and obesity. Cardiomyopathy, sometimes you see both features.
Yeah.
And then there's a comment about, I can imagine that a lot of these obesity are also hypertensive in life.
Yeah.
And see a lot of crossover. There's also a comment about the use of SADs. So Anna Green has commented on the converse, in an otherwise negative autopsy in an obese person, should we avoid using SADs? Would these be better attributed to obesity cardiomyopathy, especially if there's increased epicardial fat? And finally, there's a comment from Adrian Chen who says, do we need to define obesity differently or by different measures? For example, waist circumference or waist to height ratios. Perhaps one of those definitions might be worth investigating as a criteria.
Okay, I think those are all very good comments. I'll address the SADS one first. I think anybody under 45 whose sudden death should be considered for genetic screening, irrespective of body mass, as potentially a SADS death. So I think you know, the SADS criteria largely are less than 45. And we do occasionally use it older than that, but it's not common. Or we can usually fudge it with a bit of coronary artery disease. Once
it does us no harm to take the genetics.
So I think at 45, I would still, under 45, I would still consider SADS, put it in the narrative and make sure there's genetic material, because there is a potential inheritable component to that. So that's how I deal with that.
And obesity tends to run in families, you know, so we have to be realistic about this. It's not just that they can't stop, you know, sort of going back for seconds. It's the fact that it seems to be something that runs through families. So that is worthy of investigation. And was more?
There's just another comment from Jamie Robinson about there are lots of causes of death that upset family members, including cocaine use, alcohol dependency, but he doesn't think that avoidance of upset should be a consideration in terms of formulating a cause of death.
I would agree with that entirely. I merely flag it up. You do get pushback from families, so you just, you know, just assume the brace position and see it through if that's what you think is going on.
Has anyone done a study looking at fat in family infiltration versus BMI to prove, you know, to show that it's that you don't get it at lower levels, you know, not the obese? And I'm just wondering, you were talking about this intramyocyte.
Intramyocardial
Droplet formation
yeah.
and stuff, and should actually you have intramyocyte fat as opposed to fatty infiltration, which I'm not. I don't know how specific that is.
Oh, if you do frozen sections and take vacuolated myocytes, you'll find fat in everybody. And most people, as they get older, will get vacuolated myocytes for whatever reason. So I'm not sure how sensitive a test that would be to look at it in that way. Okay, criteria. I think you should have, so no valve or significant coronary artery disease has to be a given for that. You shouldn't have a history of diabetes mellitus, certainly not of hypertension, because otherwise you should probably classify it as hypertensive heart disease. And you can put obesity in as a cofactor. Tissue diabetes, I'm less certain of. I mean, I think if you're going to be purist about this, there is a so-called diabetic cardiomyopathy. And there's no doubt that diabetic heart function does deteriorate for lots of reasons, and they have more coronary artery disease and all the other things. But there's also a metabolic component to that in diabetes. I've not really done the detailed exploration of that to understand it quite so well. So I think there's there. Excess cardiac weight, yes. And we're talking about, well, what does it mean if you do this? I mean, the usual estimate is 0.5% of body weight plus 15% minus 10% will give you a rough bracket. And that's what I tend to do in my head, because I can do that in my head and it saves time trying to find the charts. But it's usually somewhere around about that to do that. In the morbidly obese patient, I work it the other way around. I take their height, okay? So what should a normal weight be if they had a BMI of 25? And then work out, if they had a BMI of 25 for that height, how much would their heart weigh? So I reverse engineer the heart weight, going back to what their normal heart weight would get completely confused. Okay.
I was saying, John, the noise is off stage. I couldn't quite hear you. Do you want to give that last bit again?
So the point is if you normalise that person for their height to a BMI of 25, you can work out what their normal body weight would have been for a person of that height. which then says, well, what would their normal heart rate be? And you can compare to that. And that kind of gets around some of the sort of, well, it's all body fat. How do I assess the heart rate? So you can just do a reverse calculation, and it's not a validated system, but it actually gives you an idea. Well, if they were normal size, what would their heart rate have been? Oh, hell, that's massively increased. You know, and it just gives you a feel of how much weight, how much additional strain has been put on their heart, because the only factor they've got or appear to have is obesity. Called.
Sorry, how do we go back to? You said you could calculate the expected body weight for that height.
Yeah.
How do you do that?
Well, it's body weight divided by height squared, isn't it? So you just move it over the other side. Take the BMI, times it by height squared, and then it'll give you the weight.
The weight should be with
Yeah.
a normal BMI.
Yes, yeah. I usually do a calculation based on 25.
And then you calculate the expected heart rate by 4.5%.
Yeah.
Okay.
And I said, well, if that was to be in their body weight, if they'd be normal size, what would their heart rate have been? And just gives me an idea about how excessive the heart weight is. Because otherwise, I don't know how to think about heart. I don't know how to think about heart rates in obese people because I just don't. I've got no reference points for it. So it's just one way of doing it. Four-chamber dilatation. I mean, when you read about it, people say that, but I don't think you need that. If they've got systolic dysfunction, they'll have four-chamber dilatation. Full stop. If they've got diastolic left ventricular function, their right left ventricle may be normal size, not dilated but thick-walled, but you will have dilatation in the left atrium and the right side. Yeah. So in diastolic hearts, left atrium is enlarged, and you get right ventricular hypertrophy and right ventricular dilatation because you essentially are running it like a. That's what happens in HFpEF in the hearts. So I think you've got to have chamber dilatation. You've got to have a big heart. It's nearly always on the right side. The left side is variable as to whether you've got it. If you haven't got left ventricular dilatation, you should have left atrial dilatation because that basically shows you've got increased filling pressure. And we know from hypertension that is an independent adverse prognostic sign for death to do that. Histologically, myocyte hypertrophy, minor interstitial or perivascular fibrosis, but there aren't going to be any specific features that we can go looking for. There's no good literature on correlating BMI with the amount of fatty infiltration in the right ventricular wall. So my gut instinct is that you see more in fat people, but quantifying it or making a statement about it, I think, is impossible. And then what BMI should we be taking or saying that this is going to be adverse? So my current practice is and you can check on the GP records usually what their BMI being. Most GPs occasionally weigh patients. They certainly don't measure their blood pressure that often. But I think anybody's got a BMI that's persistently more than 35, certainly more than 40. I think in the 30 to 35 range, as we know, there are a lot of people who are in that range, and we don't quite know what's doing. Most of the studies that have been done on obese people have been done where they're higher than 35 in the clinical arena, because they obviously want a sharp, clear cut-off from those. So that would be my sort of advice as to where to use that.